Our next question, the patient says, can you get a significant prostate cancer recurrence without any change in PSA?
I'll say the answer to that is no. There's probably going to be one patient in 100,000 that someday will manifest a truly non-PSA producing cancer, but some are low producing. So if your PSA goes from 0.02 to 0.06 to 0.1, that's not a lot of PSA, but it could be a significant change. But to have cancers growing with completely undetectable PSA is something I don't see.
So this next patient has a Gleason 3+4 and they're considering active surveillance. Can you please tell me what tests I need to take in order to be confident that I truly have low-grade cancer?
So this controversy continues to rage on. There's some complexities here. Generally speaking, people are insisting on Gleason 3+3 for active surveillance, but it turns out that there are situations where 3+4 can be a consideration for active surveillance. One is when the 3+4 setup indicates that 5% or less of the biopsy is 4. So it's very, very little 4. And this needs to be reviewed by world-class experts to confirm it. So if that's the situation, experts are telling us that the 3+4s with less than 5% grade 4 behave like 3+3. And if it behaves like 3+3, in my mind, it's time for active surveillance. There's also evidence that 3+4s with 10 to 20% grade 4, perhaps in just one core, do very well. There's a little bit of risk doing active surveillance, but not much risk. Those are the types of patients I like to order Oncotype or Prolaris and find out if the genetics line up as well and suggest that the likelihood of spread is very, very small. And then men just have to kind of weigh their own priorities. We know that you're going to have some risk of erectile dysfunction with any kind of treatment, and that's an immediate problem if treatment is implemented. So some men are willing to take a small chance. Let's say there's a 3 or 4% chance of the cancer spreading over 10 years. That may seem like a reasonable risk, considering that the risk of ED from treatment could be anywhere from 25 to 50% immediately. So there are men with 3+4 that do decide to watch their situation rather than treat it after all this analysis is finished.
So you mentioned having world-class experts read pathology. So that's Jonathan Epstein from Johns Hopkins. And if, the patients, if you guys need that information, you can contact the PCRI and we can get you to him. He has a whole referral site for second opinions for that. The other things that you mentioned are, the monitoring process. So what would the PSA need to look like? How often do they need to get their PSA tested if they're going to choose active surveillance in this category? What does the imaging protocol look like?
Well, we typically will check the PSA 2 to 4 times a year and get a multiparametric MRI at a center of excellence and do a color Doppler. That's our policy. Most of the country is doing periodic random biopsies. Every 3 years, they'll go around the clock and make sure that there's no new cancer there. So our methods have worked for us. We're very careful in terms of the imaging doctors that we use. And of course, we do the imaging ourselves, so we're very hands-on in that regard. But typically, across the country, there's more reliance on random biopsy to monitor men. And anywhere, it depends on how old the patient is, how high the risk is. But Johns Hopkins for many years was doing biopsies every single year, which I thought was kind of ridiculous. But that idea of depending on random biopsies has been the standard and continues to be the standard.
So what would the PSA look like as far as monitoring? Do they need to get it every 3 months, every 6 months, once a year?
Yeah, initially every 3 months to get a baseline, and then maybe twice a year after that. And PSA needs to be interpreted in relation to how big the prostate is. We know that if the prostate's 40 cc's, you divide that by 10. Normal PSA is around 4. And if the prostate's 80 cc's, you divide that by 10, and normal PSA is around 8. And so people need to look at the relationship between the PSA and how big the gland is. So when the PSA density starts going 50% above that, so if someone had a 40 cc gland, if their PSA is running consistently over 6, then that's the time you start wondering, well, why are we having all this extra PSA? And maybe there is a place for doing a random biopsy or making sure that something isn't being missed. in terms of the relationship of PSA to prostate size.
So when you have a 40 cc prostate, the PSA should be below 6. What do you do when you have a patient who's in the 3+4 category trying to choose to do active surveillance, but maybe there's, prostatitis or BPH in the way that's also causing the PSA to go higher? Is it very difficult to delineate those two?
It can be. And this is where sometimes you have to go get more information and in some cases perhaps even do a random biopsy, make sure something's not being missed. The diagnosis of prostatitis, that's inflammation of the gland unrelated to cancer, is what we call a diagnosis of exclusion. In other words, we've looked carefully, we haven't found any consequential cancer, and therefore we assume that the high PSA is running high because of the prostatitis, not because of some cancer that's being missed.
So this next patient is 56 years old. They have advanced metastatic prostate cancer. And the person says, my PSA dropped immediately when I did Lupron and Xtandi, but now his doctor wants him to do radiation as well. So he's going, if my PSA has dropped, do I even need to do the radiation?
So there actually have been some nice clinical trials looking at doing radiation alone or hormone therapy alone or a combination of the two in men with locally advanced or high-risk cancers. And when radiation was scary bad 15, 20 years ago, we would rely exclusively on hormone therapy, and men get lovely responses. The issue, of course, is that when the hormone therapy is stopped, typically the cancer will come back, and so you're sort of locked into lifelong hormone treatment intermittently or continuously. And the radiation gives you a chance of getting more durable remissions. But those studies that I mentioned do show better 10-year survival rates in the men that do radiation plus hormone therapy as opposed to doing either radiation alone or hormone therapy alone. So it's more effective to give the combination. Are there times when you decide that's not necessary? PSA has become undetectable, perhaps the patient's elderly, and decides that, for some reason doesn't want to do radiation, it may be acceptable. Every situation needs to be individualized. Radiation has gotten a lot safer over the last 5-10 years with SpaceOAR and other techniques. And so the permanent damage from radiation these days is mostly the risk of erectile dysfunction, which if someone's on continuous hormone therapy, that usually doesn't represent a big issue.
This patient wants to know if a PSMA scan fails to find any sort of cancer, but they have a rising PSA, should they go ahead and do an Axumin or a choline PET scan to maybe try to find it?
Yeah, it makes a lot of sense because the PSMA PET scan works by a different methodology, and we know that these cancers have different biologies. So 5-10% of cancers don't make PSMA. And to go searching with another methodology like Axumin or C11 choline makes perfect sense. The sensitivity of Axumin and C11 choline is not quite as good as PSMA. PSMA PET scans, you can start looking for cancers with PSAs as low as 0.2. Typically with C11 choline, you want the PSA to be at least 0.5 to 1, and for Axumin, probably above 1 to 2. But there's no reason not to go on a continued search with these additional scans if the PSMA PET scan is clear.
Our next question is, how long do you need to wait and see if a second-generation anti-androgen works? This patient has a dad who's took enzalutamide 2 months ago, and it looks like the PSA hasn't, gone down at all.
Generally, 2 months is enough. The Zytiga and Xtandi, Nubeqa, Erleada type agents will work and be reflected in PSA pretty quickly, 30 to 60 days. I think if you're 60 days in and the PSA hasn't declined, that it's probably not going to decline.
Hi everyone, it's Alex and Hunter. Hunter's our official PCRI mascot. If you'd like to learn more about men's health tips and prostate cancer, you can follow him on Instagram, Sir Hunter the Dow, and also subscribe to our YouTube channel. We come out with new prostate cancer videos every week. Say bye!